In the next 12 minutes, I will talk you about treatment in mono-infected as well as in co-infected patients. I have to run. I have nothing to disclose. First of all, I would like to provide you with a basic clinical background. The main reason is that I think that we should know why we will have to treat our children with hepatitis C, as well as in mono-infection as in co-infection. And of course, we will talk about the present treatment and the future of treatment of hepatitis C. Let's start with the natural history. These are the results of the Italian Observatory for Hepatitis C. Is still the largest cohort ever published on hepatitis C mono-infection. I would like to try to focus your attention on the prevalence of cirrhosis that is less than 2%. There are many data in the literature. I would say that we should keep in mind then that in mono-infection, only few children will develop advanced liver disease, that is bridging fibrosis and cirrhosis. Usually we would say less than 5% of the children with mono-infection. With regard to co-infection, we should start from adult data. And what they have demonstrated is that fibrosis progression is accelerated in the context of co-infection, that co-infected adults have a higher rate of liver failure and, of course, of death related to hepatitis C. And also it has been demonstrated that adults develop hepatocellular carcinoma at younger ages when compared with mono-infected adults. Up to, I would say, 1 year ago, the literature with regard to co-infection in children was almost limited to small case series. Then the data that Claire were reporting a few minutes ago were started being published and reported in different meetings. I will refer in the next few slides to this data and to this cohort of more than 220 children and adolescents with co-infection. Trying to summarize, I would say that HIV impacts every aspect of hepatitis C in the context of co-infection. It increases the risk of vertical transmission. It reduces the rate of spontaneous clearance of hepatitis C. That is about 20% in mono-infected children, and is associated with higher viremia levels and also with higher ALT levels. But what is more important is that it worsens the natural history of the infection. Across the different studies, what we can see is that while end-stage liver disease is very uncommon in mono-infected children, has been reported many times in the few studies of co-infected children. That makes some sense and gives us an idea on how could this infection, this co-infection, be severe with regard to liver involvement. Anna Turkova published recently this data. We as hepatologists trust only liver biopsies. But we should say that transient elastography, the so-called FibroScan, have some impact because it is able to discriminate between children and adults with advanced liver disease or with the absence of fibrosis. And if you look at the result of this study, you will see that about 15% of the children enrolled present FibroScan values more than 9.5%. That means advanced liver disease, bridging fibrosis and cirrhosis that is much higher than the 5% that we described in mono-infected children before. So let's try to summarize. We can say that in the context of co-infection, children as well as adults have a more severe liver disease. And nowadays, we can treat this infection, hepatitis C, only with 3 drugs: pegylated interferon alpha 2A, pegylated interferon alpha 2B, associated with ribavirin, 24 weeks of treatment for genotype 2 and 3, and 48 weeks for genotype 1 and 4. The performance of this drug could be considered good for genotype 2 and 3. As you can see, 89, 90% of virological response rate. That means eradication of the infection after 24 weeks of treatment. 1 out of 2 children with genotype 1 and 4 will achieve virological response with this treatment. The results of pegylated interferon-based treatment in co-infected children. Let's say good for genotype 2 and 3, around 80%, 10% less than mono-infected children. But I would say not so good for genotype 1, around 30%. And we should not stop at the numbers. We should look what is behind the numbers. For example, the co-infected children treated and reported in the previous slide were treated for a mean duration of 48 weeks, 47 weeks. That means almost 1 year of treatment. And we all know the safety profile of pegylated interferon that is really hard to be tolerated in children. And also, if you look at those children that are in a highly need of being treated, those with advanced liver disease, the efficacy of the treatment is much lower, around 10%, 12%. But we are very lucky. We are living in an exciting moment. In 2011, new drugs have been developed and a new era in the treatment of hepatitis C has started. As you can see here, I try to summarize the 4 different categories of drugs that are currently available, and those are direct active antiviral agents. Each category is different from the other according to the, of course, to the target of the drugs, to the resistance profile, the genotypic efficacy, the antiviral potency, and the safety profile. This list is incomplete. There are a number of drugs that are available, and those are only the drugs that are already approved for adults or are in phase 3 studies. But I think that we should try to focus on the rationale that is behind the development of these treatment associations. When the backbone of the treatment is based on a nucleoside NS5B inhibitor, mainly sofosbuvir, then only one drug is usually needed to achieve very high virological response rate, around 95%. When the backbone is the non-nucleoside NS5B polymerase inhibitor, then 2 drugs are needed to achieve the same goal. And there are some promising regimens that are based on protease inhibitors and NS5A inhibitors without the NS5B polymerase inhibitors. So what's going on the mono-infected adults and co-infected adults? We don't have pediatric data, so all these slides are from the adult side. Let's start with one association. I try to focus on 3 different associations, are the ones that have been developed both for adults with mono-infection and with co-infection. Let's start with the fixed dose combination with sofosbuvir plus ledipasvir. That means 1 pill per day. That is completely different from pegylated interferon. It's something new and really very, very close to what we were aiming for our children with mono and co-infection. So the virological response rate for genotype 1 patient are around 95%. And as you can see, 8 weeks of treatment could be enough because the virological response rate are around 94%. What is surprising is that in the so-called difficult to treat population of co-infected adults, the same association used for 12 weeks of treatment was highly effective, 96% of virological response rate. Let's change association. This is the so-called 3D association of paritaprevir boosted with ritonavir, onbitasvir in a fixed dose combination together with dazabuvir. Genotype 1 adult patients, genotype 1A and 1B, the same efficacy around 99%, 97%. Again, in co-infected adults, the numbers are even better, 99%, 97%. And you know, only 5 patients in this study did not achieve SVR. But if you look closely at the result, you will see that only 2 of these 5 patients were really one virological relapse, 1 breakthrough. The others were probably patients that would have had a good response to treatment, but 1 withdrew their consent and 2 were reinfected, and there was the phylogenetic evidence of reinfection. And then sofosbuvir plus ribavirin, the standard of care for genotype 2. As you can see, 97% of sustained virological response rate in mono-infected patients. For genotype 3 was an easy-to-treat genotype with pegylated interferon-based treatments. Now it's an hard-to-treat genotype. If you go up from 12 weeks, and as you can see, the virological response rate are a little bit on the low side. If you go up from 12 weeks to 24 weeks, then you can achieve 93% of virological response. That is very good for us. And the same is true for genotype 4, 24 weeks in a pilot study, good results, 92, 84, 89%. This is not the best treatment that we can have for genotype 4. But the point is that recently these data were presented and published, and this is only an example of a pangenotypic association that could be given to all the adults with, independently of the genotype. And you know, in the interferon era, we would have been very happy to see 85% of virological response rate. Now we are not so happy. We are looking for 95%, but this is only an example of what we can do with the same two drugs in different genotypes in adults. Of course, we need to study, we need to be very careful. You will teach us on how to do it because there is the possibility of drug-to-drug interaction. I don't know if this is the answer, but there are wonderful guidelines that could guide us in choosing the right association or can guide us on how to move according to the different association that we will use. So trying to summarize, I would say that my conclusion, my take-home messages could be that hepatitis C in co-infected children could be a severe disease. This is the main reason why we should try to treat them as soon as possible. That new drugs, new direct-active antiviral agents will change the paradigm of treatment. We should think that we are not aiming at treating a disease, but we should move forward to the idea that we should eradicate an infection and prevent a disease. So as soon as possible, 3 years. Let's say that in my mind would be even earlier. And the most important aspect is that HIV, HCV co-infected children and adults are no longer a difficult to treat population. Thank you for your attention, but also thank you to all my staff in Florence and to the PentaHep group, to Carlo, Claire, Anna, on behalf of all the others. Thank you.